Hello and welcome to a video in the FRCA Notes series, where each video aims to summarise an article published in the British Journal of Anaesthesia Education. This video aims to summarise the article entitled Laryngeal Complications After Intubation and Tracheostomy, which was published in 2021. In this video, we'll discuss what complications can arise, what are the risk factors for these complications, how we can diagnose them, and how we can manage them. So complications can be classified in different ways. In this video, we'll talk about the time of onset and anatomy as different classification systems. The complications of intubation can be classified by the time of onset, and these can be early, late, and very late. Early complications include laryngeal edema, vocal cord palsy, paresis, atrophy, and ulceration, desensitization of the laryngopharynx, aspiration, dysphagia, intubation granuloma, erythema, polyp, and temporary hoarseness. Late complications can also involve laryngeal edema, vocal cord palsy, paresis or atrophy, aretinoid cartilaginous trauma, aspiration, dysphagia, anterior glottic web formation, and prolonged hoarseness. Very late complications include glottic or subglottic stenosis, laryngeal or tracheomalacia. Complications of tracheostomy are the same, plus stoma infection, wound breakdown and granulation, incoordinated glottic closure, vocal cord tremor, and prolonged cough inflation, which can lead to desensitization, poor cough strength, stasis of secretions, and this can compound aspiration risk. So now that we've considered a time of onset based classification, we can also think about an anatomical classification. And here we can see a few diagrams labelled with potential areas that complications can occur. These include aretinoid cartilaginous trauma, desensitization of the trachea, nerve palsies, vocal cord edema, necrosis, granulation, glottic or subglottic stenosis, tracheomalacia, psychological complications and distress as a result of the development of other complications, impaired saliva management predisposing to aspiration. So, what are the risk factors for complications? These can be divided up into patient-related risk factors and procedure-related risk factors. Patient-related risk factors include age over 50, laryngopharyngeal reflux, female gender, obesity, diabetes, and malnutrition. Procedure-related complications include multiple reintubations, surgery type, including cardiothoracic, thyroid, head and neck surgery, emergency or prolonged intubation, or a reduced skill level of the operator, coughing, prone positioning, cuff pressure that's high, or a high tube diameter. So how can we diagnose laryngeal complications after intubation and tracheostomy? We can consider this as screening investigations and diagnostic investigations. A cuff leak test can be used to predict laryngeal edema by deflating the cuff. In the presence of laryngeal edema, a leak would not be present. Speech and language screening tools also exist to screen for dysphagia, but they often miss silent aspiration. Diagnostic investigations can be for dysphagia and for dysphonia. Functional endoscopic examination of swallowing which uses a flexible nasoendoscope, can assess interventions and also have a direct view of swallowing. For dysphagia, video fluoroscopy can also be used, but this would require transfer to the radiology department for this investigation. For dysphonia, video stroboscopy of the vocal cords can evaluate vocal cord vibration. Examination of the larynx under anaesthesia can also occur. So how do we manage these complications? And as you can see, management involves the speech and language therapists, nurses, respiratory physiotherapists, the intensive care doctors, and head and neck surgeons. And as such, we could say that the management is multidisciplinary. We can divide management up into the management of laryngeal edema, secretions, dysphonia, and dysphagia. Laryngeal edema can be managed by dexamethasone. It's important to treat resultant hyperglycemia, delirium, and weakness. In addition, if the patient has reflux, either gastroesophageal or laryngopharyngeal, then a PPI should be added. Secretion management can have simple measures such as upright positioning, good mouth care, and oral and subglottic suctioning. Pharmacotherapy can also be used, and this could include atropine eye drops, glycopyrronium given intravenously, a hyoscine patch, or injection of botulinum toxin into salivary glands. Other interventions include restoring translaryngeal gas flow, which can try and promote recovery. This is done with early cuff deflation trials, the use of one-way inline ventilator speaking valves such as Passy-Muir valves in patients with tracheostomies, above cuff vocalization, which can assist in clearance of saliva. Salivary gland radiotherapy may be indicated in chronic patients. Dysphonia and dysphagia can be managed in a multitude of ways. Speech and language therapists can use voice and swallow exercises. Laryngopharyngeal function can be promoted by using pharyngeal electrical stimulation. Biofeedback can be used by using surface EMG to augment swallowing. Surgical options for vocal fold paralysis or stenosis include vocal cord medialization, reconstruction, a retinoid adduction, vocal cordectomy, and dilatation for stenosis. Surgical options for tracheomalacia include tracheal stenting or tracheal reconstruction. So that brings us to the end of this article. At the bottom of the video in the description section, I've included some useful links, which include a link to the article itself, as well as a link to a quiz I've generated, which should hopefully try and consolidate some of the knowledge we've covered in this topic. Finally, there's a link for a feedback questionnaire in the description section, and this would be really helpful and useful if you guys could try and fill this out, because I will read through everything that's said and try and use the feedback to try and better the next videos. Thank you so much for your time. Thanks for watching.